So thanks for doing the stand. I appreciate it. And I guess what we really want to start with is just what you were working on when the pandemic sort of began. Like, where were you working and what were you working on?
Yeah, that's a good question, Bruce. I, like everybody else, life was normal before before COVID. So I was doing quite a lot of work internationally. So I was living between Miami, New Jersey, and Switzerland at the time, consulting with the large multinational on healthcare strategy. That was part of it. I also have another company called Clover Hill Healthcare, which basically has some interesting technology for nasal congestion and allergy. So we've been rolling that out. We're now in 20 markets, and we just launched in the US under the leading brand called NeilMed. So we're organizing all of that.
Mhm. And when you like, I think when you're an entrepreneur or you're in business, your way to help is to try to look for business opportunities and ways to jump into a problem like that, like the pandemic. It's a call to arms, but I guess in your answer would be different than, say, a scientist or a doctor. You're trying to provide a service. So where did you start to think there's a way that we could help out? There's a service we could provide, a product that we could generate out of this.
Yeah, I think I would categorize my entire 35 years in pharma consumer as someone that tries to solve problems, right? I look at the world and I go, wow, that's not right. How do we fix that? What makes that tick, and try to understand it. So I think I was like everybody else when this actually started to break. I was in Japan, again, consulting, and I sat with a thoracic surgeon who happened to see one of the first COVID patients coming through Asia.
Hmm.
And this is in Tokyo. And he said to me, he says, I've never seen anything like this. He says, this is really bad. And he said, I'm surprised. And this was January 20th, I guess.
Hmm.
He says, I'm surprised if you get out of the country. And I was kind of taken back by it. He said, this is real. This is serious. And then he went on to show me over the last week or two, ever since seeing his first few patients, he started to stockpile products and goods in his house. Literally, his hallways of his apartment were stacked with food, like rations.
Wow.
Because he saw the bigger picture. He said, this is going to be cataclysmic. And I kind of laughed. I thought this guy was a survivalist nut job, if I'm honest,
Hmm.
until I got back in February. And then everything obviously hit in February, March in the US. And I think everybody was panicked. Like, how does this thing spread? Is this thing so virulent that it is on every surface? And I think, like everybody else, every grocery that came into my house, if it was delivered or if I went out to get it, spraying peroxide on it. My girlfriend, who's a pediatric neurologist, she was even freaked out by it.
Hmm.
And she had, she's taking shoes off. She microwaved my wallet, for instance, because she says to me,
In
you were
retrospect,
touching
it
everything.
sounds, I
Yeah,
get
she
it.
said everybody's freaked out. So, and all my credit cards burned up. Everything was a joke. And I realized, I said, no, this something is not right about this thing. This thing must be like every other cold and flu virus, and how it's transmitted. And there I started my journey of trying to understand, all right, where does this thing occur? How does it occur? What is the major entry point, and so on. And it was probably, I don't know, this is now 2020, right? So I think around July, August 2020, we started to understand that this was an aerosol virus, that this came in droplets, that this thing is like every other thing that we know about flu and cold. And so the main vector here is the nose. I spent, more than 30 years in upper respiratory health. My group at GSK, when I was there, switched Flonase. I worked on every major cough cold product you ever saw on your shelves at OTC. And so I have a very good understanding of it. And so I said, look, there has to be a way through cleansing, rinsing, and other ways to stop this thing. And sure enough, there were some studies in Scotland called the Elvis study, I believe, and they were looking at hypertonic saline and a few other things. So it looked like this thing could be, removed, reduced through nasal hygiene. And then, having worked on Listerine 25 years ago when I was at the J&J companies, we worked a lot on plaque and other things, but we knew that these essential oil formulas were also very potent against bacteria and virus. So, and knowing the structure of the virus, a year into the issue, we knew that it could be disrupted in certain ways. So there kind of laid the groundwork to say, hey, this can be solved. Now, what really bothered me was that it's like medicine and the medical community seem to forget the basics of disease transmission. And nasal hygiene. I mean, there are study after study showing that if you clean your nose and you clean your mouth, you can reduce the transmission and infection of just general upper respiratory viruses like the common cold. So to me, all of the things that we did for common cold applied to the other situation. I don't like to mention the virus for obvious reasons, but it applied to the virus, so to speak. And no one was talking about it. And no one was putting money against simple solutions. However, there started to be some very interesting data generated in India, Bangladesh, and countries where therapeutics and simple solutions were the kind of leading front end because of cost and no, sight of a vaccine coming to that country at all, right? Even today, it's true. So I think some of the, what we used to call third world, no longer third world, but I would say countries that struggle on a US level are really well ahead of the Western world when it comes to basic treatments for a virus. And,
So I wanted to back up a bit, just if I could, because one of the things that we sort of got saddled with early is a reliance on masks. And so I wanted to just go back because before the virus actually interacts with the mucosal surfaces, we're trying to keep it out. And so that's our idea. We're going to keep it out. So I want to go over, first of all, I want to talk about the efficacy of masks as, as they relate in terms of a hierarchy. And as I understand it, in terms of PPE, the low rung on the pole is the N95. And that anything we're having surgical masks or a cloth mask is much lower on that ladder. So I was wondering if you could speak to that a little bit.
Yeah, sure. I speak with a little bit of background because in about 2005 and 6, 3, 4, 5, 6, when remember avian flu, right? The bird flu. I happened to be at GSK at the time, and my group developed the first antiviral mask ever produced in the world. It was called ActiProtect. You can see it on the internet, and it was the first bird flu mask. And basically, what we did was we coated an N95 mask with citric acid and a few polymers that deactivated the virus on contact. So with a mask, the mask gets highly contaminated on the outside. And so while it may work to reduce any type of inhaled particles, the minute you touch an outside of a regular mask, your fingers become contaminated. So we had a way to deactivate the virus. So that was, fortunately, although, we sold, I think, about, $30-40 million worth of masks in Europe. Avian flu didn't take off because it wasn't highly infectious. Now, who knows what happened? Maybe it kind of mutated itself out of existence, right? But let's talk a little bit about masks. Absolutely. So there's an N99 mask above 95. The problem is they're so hot and uncomfortable, nobody would wear it for more than 20 minutes, all right? So N99 out the window. Plus they're probably $25 each, right? And they only last for 8 hours or something like that. N95 are superior, absolutely. When you look at the filtration, they're incredibly good. But I will give you a couple of caveats. Number one, N95 masks, when they're qualified as N95, have to be fitted professionally, right? Meaning that you have to really push that bar down. You got to really, if you have facial hair, it's a problem too. So, in the perfect scenario, it's N95. And absolutely probably the best mask you can do, but it has limitations because it leaks here, it can leak around your face, and so on. So it's really not N95, right? Everything else that people are using, kerchiefs or handkerchiefs or
Gators,
whatever it may be, these surgical masks and so on. In my view of what I know about masks and having worked on it for years, is that they're good as sneeze guards. Okay, So if you sneeze, they're going to catch a lot of the large particulate. They're not going to catch the aerosolized particles that are 2, 3, 4, 5 microns. They're just going to escape either through the mask or around the mask. However, I think they do help. They do help because, you know, if you're in a room and you sneeze and you're going to have this plume of stuff go out into the room, and then you leave the room and 5 minutes later somebody walks into the room and they're going to get infected, right? So I think it does help in decelerating those particles and the trajectory of these particles, but they're certainly not anywhere near as good as an N95.
So when you look at masking and you talk about I'll give you three scenarios. One,
Mhm.
you have so three people are infected. One is wearing an N95 outdoors, and you're just walking around on a sunny day. The other is they're at a grocery store and they're picking up their goods and they're leaving. And then the other is they're visiting with a relative in a closed living room.
Right.
And they're sitting there, there's no windows open, and they're sitting there for say 3 hours.
Right.
I can only think of one of those where the mask would be efficacious. But I was wondering if you could speak to that, like maybe look at those three and now three of those three examples
Yeah.
and break them down in terms of the efficacy of a mask in each of those circumstances.
Yeah. I live in kind of two worlds. I live in Florida and Miami, where I'm now, and also Los Angeles, which you have people walking. There's nobody around people for miles. And they're double masked. So it's kind of laughable. I kind of go, they're not sane. Look, if you're outside on the beach, nobody's around you. Like, don't wear a mask. It's stupid. It's absolutely ridiculous. So that's my view. If you're out in the open, you're in the sunlight, nobody's around you for 50 feet. Don't bother, right? Enjoy yourself. Um, Now, if you're sick and you're hacking and coughing, you shouldn't be outside because, who knows? You're gonna, what you're like, it's like the beach when you go to the beach, somebody sprays suntan lotion and you smell it, three or four blankets down, right?
Mm.
So it's possible you can aerosolize somebody, but it's rare. It's very rare. All right, so you have somebody in the supermarket wearing a mask, right? Again, probably not needed, right? Probably not needed. Ventilation is usually pretty good, and there's enough airflow. Okay. If you're in a closed room with somebody who may or may not be sick, you don't know, you may be sick. Um, you know, Probably, if they're older, right? They're young people. Who cares? They're fine. If it's an older person, maybe have a little respect, wear a mask, or you know what? Open a window.
Mm.
Open a window. Get a fan going. Right? Circulate the air. Do the common sense stuff, right?
Mm.
Because if you circulate the air, you open up a window, you're probably going to be fine. Turn the heat up and open up the cold air. Let the cold air come in. Who cares? Let the fresh air come in. Not a bad thing. But I think air circulation is one of the areas that are totally underserved. And building ventilation, totally underserved. If we can get ventilation done correctly in public spaces, and this is a whole big project, I'm sure, then a lot of these issues go away. Pull the air up, pull it down. In the pharmaceutical space, we have something called class 100,000 air or class A air. This is where you have high circulation through HEPA filters and the air moves, exchanges 8 times an hour or something like that. You're never going to get sick in an area like that. I'm not saying it's what every home needs, but certainly in public spaces, you need to keep the air moving. There's no other way.
And when you have you're talking about the HEPA filters, what about I've heard that they're actually talking about treating air with ultraviolet light as it goes through a filter to try to
Sure.
kill organisms. Is that something that might be on the horizon?
Well, they do it today. They do it today with.
I meant like a widespread, more widespread. Do they do it?
I hope so.
Yeah.
I hope so. Yeah, I absolutely hope so. I think it would help with allergy. The UV light destroys a lot of things, not just viruses and bacteria, but I think, look, HEPA filter is definitely a need, and UV treatment is definitely a need. I mean, UV treatment's been used, filters and UV treatment has been used for water for decades, and so there's no reason why these principles of water treatment could not be used for air treatment. They're very basic principles.
I'm wondering about like, I've heard it said that people are concerned that the immune response might be depressed by not having a resistance. So if you eliminate things for the body to fight against, the immune response could become depressed. What are your thoughts about that?
Well, I don't think we'll ever have a very clean environment. We can only wish. I mean, everybody's obviously in their home. A lot of people have gone to, hardwood floors. They've gone to, hard, soft furniture, not like these, like this furniture is probably, it's clean, but who the hell knows
Yeah,
what's in it?
right.
But I think we're always exposed to allergens and other things that I don't see us being ever in risk of being in a sterile environment where our immune system breaks down. I don't ever see that happening.
Yeah, okay. Because I wondered about that because I know that their concern is if kids are growing up and they're never, they have
Right.
an antiseptic environment, they're never not getting out. When you and I were younger,
Mhm.
you would be playing outside, you'd be playing in the mud, you'd be playing in the dirt, you'd be outside
Yeah.
all day, and so you have a lot more to fight against. I just
Yeah.
wondered if we're making
Well,
we could make it.
what you yeah, well, what you raised is very true. There are studies actually with twins. One was raised, I think, Amish. Another one was raised, certain ways, and the ones were raised on the farm. There's no question that if you're going to raise your child, get them exposed to a lot of things, cats and dogs, and you're not going to tell them to eat off the rug for God's sakes, but you got to expose them. You got to expose them to things, right? And in fact, this whole thing around peanut allergy, if you read the recent treatments for peanut allergy in kids, is to expose them early to peanuts,
Mm,
right? It's not to keep them away from it. It's to introduce peanuts earlier under the supervision of a doctor, of course. But then you build up a tolerance. And yeah, that's what it is. I do worry, we use these gallons and gallons of hand sanitizers, and it's just a joke. We know that, some viruses are spread by hands. We know that. But for what we're talking about with respiratory viruses, they have virtually no bearing on how clean your hands are,
mm,
unless, right, the very rare chance that you touch something or literally you touch your face and nose. That's really the worst. You touch your face and your nose because your nose is the air cleaner. 70,000 liters of air go through your nose and mouth every day. So it collects everything. So the
mm,
worst thing you could do is touch your nose and then touch your eye, right?
yeah.
So a very low chance of infection, but common colds are spread that way.
But as I understand it, COVID doesn't exist very long on surfaces. That was the concern, as you mentioned earlier. There was early on that we were concerned that it was going to live on surfaces for days and days. But I think they found in studies that it wasn't existing to the length of time, and there were very few surfaces where it actually was able to sort of maintain itself for any length of time.
Yeah, I've seen, some of the wild studies in the beginning where it was, 21 days on a cruise ship, some crazy stuff. Now, was it the proteins or was it the intact viruses? So you got to look at this data pretty, skeptically and say it's probably the proteins that they detected for, which means it was proteins, but not the full virus. It's not going to get you sick. At best, the way I would look at it is, a lot of these viruses probably can last 5 to 10 minutes, on the
Mm,
surface. But on the surface, they're hard to, contract because it's mostly, it needs to get in your nose, right?
mm,
So what are you going to do? I mean, you really got to think about this creatively of how you get your finger up your nose that high with, after you touch something.
yeah.
So it's really going to be, airborne. And for that, we know what to do for that.
And what percentage of the like when you're if you were dealing with the infectious material, if you had to break it down, what percentage would be particular and what percentage would be aerosol in terms of what could infect? Like, so is the majority of it in the particle form, is the majority in the aerosol form?
Yeah, that's a great question. I don't know if anybody knows the exact answer, but the current view is it's aerosolized droplets, right? These are droplets that are sneezed or coughed out of the mouth, right?
Mhm.
So entrance and exit, right? And we're talking about particle size. There's somewhere around 2 to 3 microns, 5 microns. For the most part, your mouth and your cough is good at, obviously spraying and getting distance and so on. It's not very good at making what I would call micronized droplets because there's not enough energy there. to really get it down to like, 1 micron, 2 microns. They're probably going to be more like 5 or 6, and they're going to be high. So they're going to collect more in the upper respiratory. The cutoff for particles before they go to the lung is roughly 5 microns. Once you get 5 microns, it goes right into your deep lung.
Mm.
Because this is an aerosol virus that mostly starts in the nose, you're talking above 5 microns and above probably 20 or 30 microns. It's not going to suspend in the air; it'll fall to the floor.
Mm.
So the particle size in aerosols are probably around 10 microns. I would guess, based on aerosol physics.
And that's where I guess the masks, I have an issue, because you have a mask that has, I've heard the pore is often in a cloth mask can be anywhere between 50 and 80 microns inside. So you're potentially just breathing it right through the mask anyways.
Yeah, I think, the bigger risk is kind of blowing around the mask, because no mask fits perfectly, right? For an N95, the risk is the fitment of the mask around the face. That's really where the risk is. For the rest of them, they're just, they're not intended to be filters. Surgical masks are basically sneeze guards. That's all they are.
I was wondering, like, so the next thing, if we think about someone who is now, say, breathed in through their nose, the COVID has come in and it's interacting with the mucosal surface. So how does it now, like, is there an incubation period in the nose? How does that viral load spread to the rest of the body?
Yeah, that's a great point. So viruses by themselves can't move. They're dead. All right. They are absolutely they're particles. Okay. They're particles. So they're inhaled into the nose. The first thing they encounter is really your mucus layer. So your proteins, your glycoproteins, which are protectants and protecting your nasal lining. And so ultimately they got probably 2 ways they get to the nasal lining to dock with the cellular material on your nasal lining. They either move through a phenomenon called Brownian movement, which is just random motion of something vibrating. Yeah, everything vibrates in place, basically. You just don't see it. Everything vibrates. And basically what it does, it'll sift its way through the mucus where it finds the nasal lining. That's one approach. Second approach is it hitchhikes. These things hitchhike on other bacteria that are moving, right? That actually have ways to propel themselves. All right, so fine. That's 2 mechanisms potentially. But the reality is it takes several days, I believe, at least a day or 2, if not 3 or 4, for it to really find its way to the nasal lining. Unless you have no mucus, you're very dry, you have a nose, you have other irritations, and you have other, you're exposed in some other way. I don't know. But it takes
like a cut or a lesion inside your nose might.
Yeah, or you've been exposed to chemical. It's like, say for instance, you clean your bathroom with bleach and you inhaled a lot, and you kind of, because this actually happened to a friend of mine. He perfectly fine, decided he's going to clean his apartment because he was renting it, cleaned everything with bleach, called me up and said, boy, I'm so raw. He said, I said, well, you got to, do this, you got to do that. Sure enough, 3 days later, he got COVID. Why? Because he's probably irritated, right? Probably irritated, mucosal lining is irritated, it's vulnerable. So you got to keep everything intact, keeping that mucosal layer, mucus layer, clean, clear, flowing, really important for resisting infection. So I think it's 3 to 5, probably somewhere 3 to 4 or 5 days, okay, from exposure. In that period of time, you have an opportunity, if you use nasal hygiene, to rinse it out, to get it out, okay? If you don't get it out, all right, it's going to find its way to the nasal lining. It's going to dock with your ACE2 receptor. It's going to then inject its basically molecular material into the cell. And I think it's only 12 hours, 8 to 10, 12 hours. Then the cell bursts open and you have now millions and millions of copies of the viron. And that happens then over and over and over. And so you go from 0 viral titer to tens of thousands per liter, or sorry, per ml of saliva, mucus, to hundreds, potentially hundreds of millions. I think once you start to get to about 1 million virons per ml, something like that, you start to feel the effects of the virus. So you start sore throat, you start to cough, but it's mostly up here for the first couple of days, and then you go to bed. And what happens when you go to bed? You have aspiration. That means basically sucking the fluid from your upper respiratory tract into your lower respiratory tract. And that's when the virus enters your lungs. Once it gets there, you have big problems. So if you can limit the viral load and spread to the upper respiratory tract, you just have a bad cold. When it gets to the lungs, it's a big problem, or can be a big problem. So there's a window of treatment. There's a window that you can stop it, reverse it. And if you don't stop it, reverse it, there's still a window to reduce it, which is, treatment.
Now, I'm just curious. I want to go back a bit. Just everyone is different in terms of their immune response. When you look at, one of the things they've identified is that people who have low vitamin D levels, for example, have difficulty fighting off the virus. And I'm just wondering, in terms of your mucosal surfaces, is there a way? Are there people that have a stronger mucosal lining, or is this just everyone's the same, or is there a way to bolster it, or make it like, other than irrigating and keeping it clean? Is there a difference between people in that regard, or is there a way to improve it or help yourself?
Yeah, there absolutely are differences. A lot of it has to do with allergy, right? Exposure to allergens. People that suffer allergic rhinitis or allergies tend to have, more prone to, infection and other issues, because their mucosal lining is not as healthy. Their what they call mucociliary flow, or mucociliary, flow is the right word. It's so in your nasal passage, in the back of your throat, and so on, nasal pharynx, you have your mucosa, but you also have these ciliary hairs that sweep the mucus, right? They clear the mucus from all the way back here, all the way down, and ultimately within 15 minutes, the mucus that's in the top of my nose in 15 minutes will be in my stomach. Okay, that's the way the body self cleans itself. And so everybody has a little bit different sweeping action, a little bit different, mucus viscosity, health of the mucus, and so on. So this is really what affects a lot of it. And a lot of it gets down to your health of mucociliary flow. That's really a key variable in sinus health and nasal health.
You mentioned earlier that some of the third world nations or developing nations have been the ones most aggressively looking at this. So you talked earlier about, the essential oils found in something like Listerine, and I'm wondering about, simple nasal irrigation tools like a mist, or a lot's been made of the providone iodine, sprays that you can do. What are, maybe you could give me a hierarchy of how they could how these could be implemented into someone's
Sure.
daily life?
Yeah. No, it's a great question. So, there are going to be populations and children and people with thyroid disease and other people with other comorbidities where they can't use much, right? They can't really use any type of disinfectant or so on. So there, I would say, look, irrigate with either isotonic, which is 0.9% saline, or hypertonic, which means anything above 0.9. And I would recommend probably 2% salt. Okay. Irrigate twice a day, clean your nose, gargle with it, expectorate, do that twice a day. That's kind of your basic thing for anybody, regardless of age and health status. Then you have people that are kind of, healthy, and they're active, and they're around people, and they're in and out, in busy public spaces and so on. I would still say the same thing. Irrigation is not a bad thing, but you probably need something a bit more potent, a bit more stronger. And there, I would say there's basically two things that are recommended by some leading physicians, like the FLCC talks about, right? But and the science recently backs it up. Again, this is a virtually untouched area over the last year, so a lot of this data is new, right? But the most potent thing you can do is use some low dose iodine, or povidone iodine, intranasally and orally. Right, this is the betadine brand, it's the Immunimus brand, and so on. These are very, very potent at basically killing the virus pretty quickly. Obviously, there's a lot of press around it. There's been a lot of sanctions on companies for talking about, COVID and that. So a lot of companies just talk about it as being killing germs,
I
killing
noticed,
viruses. They
I
avoid
noticed the
all the other
commercials.
conversations.
They stay away from it, but they get pretty
Yeah,
close to the line. Yeah.
yeah. Even so that's, povidone iodine is by far the strongest you can do. But I wouldn't use it all the time. I would use it, if
Yeah,
you're,
you mentioned, like, I was in a room once where it was a clubhouse room, and you mentioned that you could overuse it, and I was wondering if you could speak to why that would be an issue.
yeah, iodine is part of your diet. It's part of the essential diet, right? You get enough. And with iodine, it's super safe, but in some very, very limited cases, it can be slightly irritating, right? Number one. Number two is you get enough iodine every day. You don't need to you don't need to add an abundant amount of iodine in your diet. It's not necessarily overly healthy for thyroid. Now it's transient. If you have any issue with iodine in the thyroid, it's transient, goes away, no problem. You wouldn't even know it. But I think the smartest way for when you think about health and safety is to use these povidone iodine products when you need to. So if you think you've been exposed, or you think you're going to be exposed, if to your point, you're going to someone's house, an elderly person who may be your uncle, right? Use it before you go, before you step in the door, you know? If you're going to be around people for Christmas, right? You'll be in a house of 25, 30 people. Use it. Use it before, use it after. You don't need to use it every day. If you're a bus driver, I could see you using it, more often. So, use it wisely. That's my biggest message. Now, the essential oils products, so Listerine, you can use Listerine every day, gargle and so on. And essential oils, same thing for the nasal cavity. I would do the same thing. I would use it when you need it. There's a few intranasal. Matter of fact, I'll be launching something around that space with intranasal essential oils. Again, don't overuse it. Use it when you need it. The nasal mucosa is very sensitive, right? So you just need to, use common sense. The other thing, to my point I made before, a lot of people have allergies, right? And they use intranasal steroids. Intranasal steroids also thin the mucosal lining. And so you don't want to be adding multiple things up your nose if you can help it, because you have always a chance of irritation.
So in terms of, you mentioned the essential oils, like I gather that all, throat gargles would not be created equal. Like, so there'd be different ones, like, I think any sort of regime would be helpful, I imagine, but I imagine that there are ones that are more, that would have more efficacy than others in terms of knocking down viral load.
Yeah, the povidone iodine is by far the best, hands down, super, super potent, followed by essential oils, right? The Listerine type of things, and probably close, but not too close, which you like to scope, the cetopyridinium chloride, what they call CPC. There are other antibacterial, oral antibacterials like gluconate, and which are like Paradex and a few other prescription products. Chlorhexidine is another one. They're not shown to be as good for some reason. I don't know why, but they're not as good. So I would stick with, for a gargle, the povidone iodine, I would stick with essential oils. And then obviously, as we talked about, salt water being a good one for everybody.
What about, like, I've heard people talk about two things, incredibly diluted hydrogen peroxide, or even bleach. And to me, like, I wondered if that's like, putting a drop of bleach, it seems antithetical, but is that something that someone could do in a pinch if they're just rinsing?
Yeah, so it's a great question. Swimming pool water is bleach, okay? It just happens to be lower in pH. So the problem with bleach, that you like Clorox and so on, is that when it comes out of the bottle, it's very high pH. It's like pH 12 or pH 13, okay? So I would not use bleach even in a pinch, okay? Only because it has a high chance of destroying tissue, right?
Right.
If you're around a pool or a spa, maybe you take a cup of pool or spa water, you gargle with that. That would be safe, right? Because it's the right level of hypochlorite and it's the right pH. Peroxide, I worked again many years on peroxide in many different facets. And the reality of peroxide is it deactivates very fast. Okay, and as a kid, you may remember, or even if as an adult, you get a cut, right? A blood. You pour the peroxide on. What is it first? It bubbles, right? You see these white fizz and bubbles. That's because the peroxide is totally broken down and deactivated instantly by an enzyme in your body called catalase. So peroxide does not stick around at all under biological conditions. It's destroyed instantly. Your tissue contains glutathione. It contains a lot of antioxidants, which will just destroy it. So it doesn't work. The only thing it will do, this is the funny part. So at low levels, it doesn't work. At 3% peroxide, if you use it enough, you'll damage your tissue. You'll turn white. You know, if you've ever tried to treat a cut more peroxide, you'll see the tissue actually turn white. That's because you've totally destroyed the tissue. So peroxide, to me, it has virtually no effect, you know, and I don't think there's any science on it at all. Now, what is it good for? It is good for oral care. There's no question. Okay, why is it good? Because it gets into the pockets of the gum. So if you have periodontal disease, right? Peroxide's great. Why? Put it in, the liquid quickly goes in, and it basically bubbles out, and it kills some bacteria, of course, bacteria. And bacteria are easy to kill. Actually, these bacteria in your mouth are easy to kill, but also cleans out the pocket. So it's good for oral care and periodontal disease. It's not a good antiviral.
Wait, you know, and the other one I was wondering about is that people often, I've heard people talk about taking like the providone, the 10% providone iodine that you would use on external cuts, and diluting that and using that just as a rinse, or just a few drops on a Q-tip up your nose. Again, is this something you would, in a pinch, you could use? Or because I think it's really important that people have a sense of what could they use, and what would be antithetical to trying to help you your recovery or protection.
So in a pinch, I would definitely go for hypertonic salt. All right, I would tablespoon of salt and water and use that. That's in a pinch. Salt's available everywhere. And then the other crazy thing, you know, use a pool water. But povidone iodine dilute, it's no problem. You know, provided you buy the right one, you buy the 10% povidone iodine solution, and you dilute it, you know, 10 or 20 to 1. You know, even 0.5 is fine, 0.5%. You dilute it 20 to 1 and use that, perfectly fine. If you want to, you know, dip your Q-tip into 10% of povidone iodine and swirl up your nose, I probably wouldn't use 10%. I would probably, again, dilute it, you know, by 2 or 3 times, you know, 1-2%, and then, you know, up the nose is fine. But 10% is too strong to use on any of the mucosa.
And why is that? What makes it too strong in terms of what will it do to the body in terms of reaction?
Yeah, well, mucosa so skin is fine, right? Putting it on skin that's keratinized, you know, our skin is very tough. It's not that porous. Mucosa is very, and it's not really water soluble. You know, it's not what's the right word? It has a hydrophobic coat to it, fats and oils on it. So that protects the skin from damage. Whereas your mucosa has nothing on it. It's pure tissue, plain, you know, it's exposed tissue. And the high povidone at 10% is quite acidic. It's about pH, you know, 2.53, but it's super what they call high buffer capacity, meaning it's highly acidic. And so it could burn your mucosa. That's likely from the low pH and high buffer capacity. The iodine itself is not toxic. It's really more about a pH burn, if anything.
So just diluting it would help, and it would be much easier to tolerate.
That's right. And actually, povidone iodine gets more efficacious as an antiviral and antibacterial as it gets more dilute, believe it or not. Really? It is contrary to all the belief. The reason is that povidone iodine is a complex between iodine and something called polyvinyl pyrrolidone. And it's complex this way, right? It's 10%, it's all complex. The minute you start to dilute it out with water, you start to get a dissociation of the povidone and the iodine. The iodine becomes more available. So
Right.
1% solution of povidone iodine is more efficacious and more potent than 10%.
Because the iodine is now more active in in
Correct.
your body.
It becomes disassociated from the povidone, so it's more available.
Is it possible to make the mucosal layer less hospitable to the virus? Like, so that is there anything you could do to make it so that the when it lands on that surface, it would die earlier or more easily? Is that
Yeah, I mean, that's a very good point. They're I think X Clear, right? X Clear is the nasal spray.
mm,
And I did speak to Nate Jones a couple weeks ago. His interesting thing with xylitol is that you can put xylitol on the tissue or spray up your nose, and it will reduce the attachment capability of various viruses. Okay, we'll leave it at that. And I do believe he has the data, he has the science. He's going to fight. He's going to fight for his right to talk about that.
yeah.
So I do believe that. But you do have to remember one thing about the nasal mucosa and the oral mucosa. Okay, in the nasal mucosa, like we talked about every 20 minutes, you change over the mucus. Okay, so how long is the thing going to actually last in your nose? About 20 minutes. And it's going to be diluted and washed away. Your salivary glands make about 2 to 4 mLs of saliva every minute. So it's constantly bathing your mouth, right, with liquid. So how long is anything going to last in your mouth undiluted before you swallow it? It's a minute or two, right?
Mm,
So the idea of trying to coat something and have it last is a difficult proposition for
mm.
that reason, because your mouth is and nose are constantly bathing and cleaning. So I think the better approach is to try to target the use of a therapeutic or something when you think you've been exposed, or you think you might, you think you're getting something, use it, or use it wisely when you need to.
No, I've often heard, like, as a kid growing up, you get a cut in your mouth and it would seem to heal like overnight virtually, whereas other wounds seem to take much longer to heal. And I've heard that just that it's the way the mouth is structured. It's just structured to be more conducive to healing. In turn, you earlier in the conversation, you talked about the nasal entry point as being a much more of a risk area. Is there something that is different between the nasal pharynx and the mouth and the esophagus that makes them different in terms of your ability to or a virus's ability to attack in that area?
Yeah, well, I think the mouth is much more self-cleaning. If you think about it, we got a tongue, right? We're constantly like doing this and swallowing. So the mouth, is highly cleans itself, almost all the time, instantly. Your nose, not so much, right? It's 20 minutes. The Yeah, so I think, and not every, and I think it's common that mostly nose breathe. I don't know many people that mouth breathe. And so just from a plain perspective of how much air, contaminated air, droplets, aerosols, whatever you want to call it, are actually introduced into the mouth versus the nose. I got to believe the nose is probably 80-20, right?
Mhm.
Maybe you breathe a bit out of your mouth, but I think most people breathe in and out of their nose, right? And if they're breathing in their nose, they're breathing out their mouth. So they're not breathing this way, right? They're breathing from the nose and out the mouth. So I think that has a lot to do with why the nose is also more vulnerable. It receives a lot more air, and the mouth is more protected,
And I'm just wondering, like you were saying earlier about the viral load, landing in your nose, and I'm just wondering, like, with changes to a virus and it having a higher viral load, does that affect the ability of the mucosal surface to resist it, or to,
Yeah,
you know?
absolutely. Once you get inflammation happening, your mucociliary system, the one we talked about, the self-cleaning, it shuts down basically.
Mm,
Not only that, the infection will can damage, not always damages, but it can damage all the mucociliary hairs, which are the sweeping action. So they get destroyed from, you think about it, your immune system kicking in, and your immune system, generates peroxide, it generates peroxynitrite. The byproducts of an inflammation and infection are quite damaging to the mucosa.
Hmm.
And so it is a self-fulfilling prophecy. You get the infection and everything else starts shutting down or gets damaged. And so it takes time for that to renew itself.
Does
Absolutely.
does that inflammatory stage, like you talked earlier about how if you can keep it up here and you're up above your lungs, then you
Yeah.
have a much better chance. Does that inflammation still take place in the nasal pharynx, and do you still have
Yeah.
that inflammatory reaction? Because I mean, one of the big issues obviously is the cytokine storm when the body
Right.
starts to attack itself, really,
Yeah.
through an overreactive inflammatory response. Does this, if you can keep it up here, do you still have that overreaction by the body trying to attempt to fight it in the nose?
And I honestly don't know the exact answer to that, right? My assumption is that, in these very rare cases, we get the cytokine storm. It's like anaphylaxis, right? It kicks in, and um, the question there is, can you still get that just even if you have an upper respiratory infection versus lower? I honestly don't know, but I gotta believe that your chances of having that happen is when it mostly goes to your lungs. And that's really when it's what I would call it's no longer local. I mean, it's systemic. It goes to your lungs. It's your organ and it's systemic. And I think that's when you start to run into problems.
Yeah. Especially, I guess, when it gets into your deep lungs, now you've got it going into your bloodstream, you've got it interacting, and the spike protein could be interacting in your heart, or other parts of your body, get into your brain, and this
Yeah.
when the serious inflammation occurs, I guess.
Yeah, I don't know enough about it, but I would assume that, once you get this inflammatory process happening, your body gets triggered everywhere, right? Your heart, everywhere gets triggered. It may not be necessarily due to the virus at that particular site, meaning the virus may not be there in your heart, your pericardium, or whatever, but it's triggered, from the lungs, and the whole body starts to go into this inflammatory process. So
Right.
I think that's more or less the way it happened. The thing about the lung is that it starts to break down this, Dr. Philip McMillan has done some really incredible series on over the last year on this, and it just seems that you start to really degrade the vascularity of the lung. You break a lot of vessels. You start to get clots, and then you start to lose oxygen saturation, and then next thing you know, you're in big trouble.
Yeah, I've heard a lot has been made of the microclotting and how that's,
Yeah.
you may not have this massive clotting, but these microclottings can cause incredible damage. And
Yeah.
I wonder if you could speak a little bit about your product that your company is selling right now, and what are the advantages to it, and how people might want to look into it.
Sure. We've positioned it as a superior cleaner, superior cleansing agent. And the science, doctors know how it works, which is good. And it came upon the view that we can market a superior cleanser that cleans well, but also has an added benefit of being hostile to pathogens and germs. And that's how we've positioned it. Earlier on, we had some other additional claims that people did not like, so we had to remove those, even though they're scientifically supported, like everyone else.
Mm-hmm.
So we're positioning it as a really robust nasal cleanser. It's called Immune Mist, and we also have a nasal oral cleanser, I should say, called it's Immune Mist Oral Cleanse. We sell it online at immunemist.com. Sales are doing pretty well. People like it. Extremely safe, effective, and so far so good.
And there's no group of people, like you earlier on was saying, that people with thyroid conditions, that this is well tolerated by most everyone, or is it something you should actually speak to your doctor about before?
Yeah. We do have the instructions on the product do limit use to certain individuals. We do get some individuals that call us and say, well, I have I have this condition, what should I do? We always tell them, talk to your doctor. Every medical situation's, very different. But in general, it's very well tolerated. And um, products like this, although there aren't many, for intranasal, have been used for, 6 decades safely.
Mm. I
So
just think one of the greatest concerns that most people have is their children, and they're
yeah,
looking at how do I protect my child from COVID. And I think there's been a lot of, I don't know how to say it, overreaction perhaps, or fear that's been generated about children. And I just wondered, is there a difference between an adult and a child in terms of how their mucosal layer works, or their how the virus would get. I know one of the difficulties they have is they don't even have the the ACE2 receptor fully developed, so it often is hard for the virus to actually bind. But
that's
I'm
right.
wondering if you could speak a little bit about that.
Yeah, there's a few things. That's exactly one of the big points. Early on, pediatric studies show that, basically older people with hypertension, the obese, and so on, seem to have very highly developed ACE2 receptors. It's also related to hypertension, right? ACE2, angiotensin enzyme. So, it's quite interesting interconnection between that and adults. So yes, so there definitely seems to be a connection with pediatrics not being a bit of an issue, not an issue because the ACE2 receptor. The other thing is children don't develop a sinus and a fully fledged nasal cavity, when they're young. They're still growing. And so I would also argue, based on what I know about physiology, that the children's nasal pharynx and nasal cavity, where adults are quite developed, may not be developed enough for it to be the best incubation spot for COVID.
Hmm. And
Right.
if a parent was looking to apply some of the treatments we've talked about today, what would be your recommendation? Like, would a child be able to tolerate your product? Would it help them, or is this something that would,
Yeah.
an extra layer of support, an extra layer of comfort for the parents?
Yeah. With children 12 and under, I think the best thing to do is saline irrigation. Right? You just want to clean them out. You just want to make sure that they've cleaned out the mucus. Everything gets trapped mostly in the mucus, and you just need to clean the mucus out. So I think the best thing you could do, use nasal saline. It's safe, and let's face it, kids aren't really affected by this too much, and so minimum treatment for low risk things. You don't need to escalate anything in my mind. Now, 12 years old and they're around kids, and they become maybe slightly higher risk, but not really. Maybe you could use something like that, povidone iodine or essential oils. Using Listerine is not a problem, so I would use nasal saline, and I would use Listerine for kids that are young. They may not like that much, but it's super safe and it's effective enough.
Yeah. I'm just wondering, like you had said earlier, that there would be not a huge risk, but there is some risk of perhaps overdoing it with the providone iodine. And I just
Yeah,
wondered, in any kind of irrigation, is there an issue with if someone does irrigate too
yeah,
much, can it cause problems?
absolutely. You'd be surprised. I've been in OTC medicine 35 years plus. You would be surprised what people abuse. I mean,
Mhm.
people can overuse anything, and yes, nasal irrigation can be addictive. It's like people washing their hands 27 times a day,
Mhm.
so yeah, look, you just need to use your head and say, look, use it minimally, use it when you need to, and everything in moderation is safe, basically.
What I find fascinating about our discussion tonight, and what I knew about you going into this, is that, and really, this is a conversation that harkens back to another conversation I had with another interview subject earlier on. And this individual talked about how she felt really strongly that what the government of her nation should have done is turned COVID over to the people and said, you help us figure out how to solve this. You come up with something. And I think what's interesting about your experience is that you're looking for a solution, and tried to find something that you think is effective, and you've contributed to, in a small part, to the benefit of society in this regard. I mean, I'm not trying to give you a Nobel
Yeah,
Peace Prize or anything, but I think it's important that I think industry actually does, we see the dark side of the people often like to look at the dark side of a pharmaceutical company, but there's also, the fact that industry can
yeah,
provide opportunities for help.
yeah. No, I think, it gets down to what can you simply do to stop? Look, there's nothing on there was nothing on the horizon, this is before vaccines and everything else. So you got to look at, what can I possibly do to help,
Mhm,
to work, for it to fix it.
mhm,
And I think, again, you turn towards some of the other countries outside Western world, and they were doing it. They had to. It was necessity, absolute necessity. I worked in GSK, I worked in Big Pharma. I worked with Moncef Slaoui, who was the head of Warp Speed, right? The Moroccan scientist. He was kind of like my dotted line boss at GSK.
mhm,
So I know him, and and I trust the people. So you're gonna get the vaccine. I said, of course I'm gonna do it. Why? Because I trust Moncef. He's a good guy. You know,
mhm,
so I'm vaccinated. But there are other things you can do to protect yourself. I know many people that have gotten breakthrough infections. Why? They're in crowded places. Somebody's gone salsa dancing. A buddy of mine uses bleach and, damages, all these crazy things. This is
mhm,
life. And so whether you're vaccinated or unvaccinated, you still got to guard against infection.
mhm. Just wondering, like, if there's anything that you would share, the things that people aren't even considering about this, the thing, like, what is the most unasked question in your mind, something that people just don't get or haven't asked, and you think is something worthy of consideration, or you just want to get a message out about it?
Yeah. Well, I can tell you, I mean, the simplest thing you can do, is air circulation. I mean, I am absolutely shocked by the way people don't talk about the importance of air circulation. So when you're with your loved ones over Christmas, over New Year's, try to get cross ventilation, right? Try to sit the elderly people not by the cold window, but get them in a place where there's good circulation of air. Okay,
Mhm,
these simple little things can be life changing events. So that's what the message I want to get out to people is that, look, there's an airborne issue. These are droplets in the air. Do everything you can do to disrupt the air patterns, get clean air in and the old air out. Because this is really what it is. This is not, COVID is not being spread by walking down the street, going to the supermarket. It's being spread in homes. It's being spread with people you know.
mhm.
So be smart. Look at the airflow in the room. Try to turn a fan on, and get cross ventilation. Get the air in and get it out.
Yeah,
Turn up the heat. Who cares? You know what? Who cares? You're burning a little bit extra couple bucks for the day.
yeah,
Just
yeah.
get that air going.
No, I think it's so true, and it's one of those things that was, so odd about the government imposed lockdowns, and the people are, staying in homes, and especially if you were living in an apartment block and you've got that air circulating through the building, and you maybe don't have the same level of filtration, as you might have in sort of an industrial area or in a
Yeah.
commercial space. And you're actually, in a sense, you're sitting in this stew of air
Yeah.
that sort of, where the viral load is heaping on and on. And it's, to me, it
Yeah.
seemed obvious that you would have issues with that.
Yeah. Somebody's coughing too, you got to think about it. It really, this is the entrance and the exits the mouth. But if somebody's at home coughing, try to isolate them, or get a mask on them, get them. You got to do something to minimize it because coughing is very, very bad.
Yeah. Well,
Sneezing is occasional.
this is that question about, asymptomatic spread. And, that was one of the things that, they've actually were saying, like, no, someone has no evidence of any illness, they're not coughing, they're not sneezing, they're much less of a risk to others, because it's only when they start to cough and sneeze where they're starting to
Yeah.
expel the virus. Is that not correct?
Yeah, that's correct. And, if they do some studies done, I believe it was at Harvard, where they they added some radioactive tracer to people's saliva, but basically they inject their blood, and your saliva is a filtrate of your blood. So you can actually see with this gamma camera, it kind of lights everything up that's radioactive. And you can see pretty much in the front of your mouth, even with normal speaking, you have a bit of a zone here. You have about a foot from a foot out of your mouth. There's vapor, there's aerosols coming out. But when you get 5 feet away, it's dispersed. It's very rare. So I would say, don't get up in people's faces, right? If you're gonna kiss somebody, kiss them on the cheek, and try to hold your breath. Little simple things,
Yeah.
um, to stay safe. But I get, again, next thing we got to do is start addressing is airflow and solutions for environmental air. That's going to be the next big thing, because there's no secret here. It's airborne. So what do we do?
Yeah, I know. I've had circumstances where I go to shake someone's hand, and even now, and it seems everyone, they kind of lean back, and there's a little bit of fear there, and I just remind them, no, you can shake my hand if you want. Go wash your hands, disinfect. You're not going to get COVID from shaking my hand. And it is important that people keep it straight in their mind. First of all, that if I appear healthy and I'm not, as I say, coughing and wheezing, then I'm probably fine. And in all likelihood, just washing your hands after, you'd be fine. But I think, as you say, the embrace or the hug or the kiss from someone that you love is important. You just want to be wise about it. Yeah, and that's an important point. I wondered, just short as we draw to the close, I wanted to ask you: is there anything about our response in general, whether it's through institutional medicine or governmental response, that you think has been missing in all of this, that you would have liked to see? If Stan was in charge, you wave a magic wand and you could have done differently, what would it have been?
Yeah, well, there's a lot of things that could have been done differently. The basics, right? The basics that we're talking about here are absolutely the foundation of preventing transmission and infection that we talked about. Second, this whole thing about shutting down science and shutting down opinions for the benefit of certain big companies and certain agendas, and even to some degree the vaccine agenda. They're kind of saying, well, if we talk about other things, nobody will get vaccinated. I don't think that's true. Maybe there's some people, but people understand the value of vaccines. They understand what they bring, but they wanted to just only have one dialogue. It's about being vaccinated, which is stupid. It's stupid. And the therapeutics piece should have been absolutely explored more. Not waiting to double blind, double dummy clinical studies. Do observational studies, okay? Safe drugs, and do observational studies like the ones that are being bashed in the news at the moment, the ones that were bashed during a different administration for president, which we know work, but they have to be they work in a window, a certain time frame. Don't use therapeutics when somebody's on their deathbed, okay? Nothing's going to work, only a miracle. So to me, I think there should have been a much more aggressive use of therapeutics. That's what I would have done. I would have got people to be open about observational studies. Say, fine, you know what, the right to choose, so to speak. You get COVID, the right to choose. All right, I'll try it. It's very safe, used for this problem. We're going to reapply it and repurpose it for that issue. And you're going to be part of a study. Do it quickly. And then publish results immediately.
That was the thing that I found most confusing. When the vaccines had rolled out, then the push towards the vaccine, I didn't agree with it, but I understood it. It made sense. But when we're in a triage situation where people are dying, and someone says, we're going to try this drug in a multi-drug therapy, and we're going to try this drug to try to help someone, and they say, oh, wait a second, it hasn't got a longitudinal study, it doesn't have an RCT.
Yeah, right.
Why would we trust that? You start to ask, well, wait a second, the difference is maybe that person dies. There's the risk to them is very low if they take this, and maybe it doesn't help them, but maybe it does. And in the absence of any other assistance, why not? Why not try that?
Yeah. If it does no harm, you got to try it. It's a risk benefit call. and they're doctors have to practice medicine on occasion. There's no playbook for things like what happened 2 years ago. There's no playbook. So what do? You improvise, right? You make it up as you go along, provided it's sound logic, and there's a basis for being safe with the benefit of the upside, right? As long as the risk benefits in the right direction, you push the button and move. In my mind, that's not exactly how some of the bureaucrats who have been running, certain institutions in this country have been operating. They've been operating from a point of ignorance and control, in my mind. The other thing is, we forgot basic medicine. So when this started to go around, first thing I told my friends, I said, look, we got to get a Z-Pack, and why you got to do that? I said, well, number one, you don't want a secondary infection. All right. This virus, most viral infections can lead to a secondary infection of bacterial because it screws everything up. It screws up all of your biology, right?
Mm-hmm.
And people, why would I do that? You don't have a bacterial infection. So yeah, but you don't want to have a complication on top of a complication.
Right.
And a lot of doctors, go, well, we don't give antibiotics for viral infections. How stupid, how ridiculous. There's no playbook, so you improvise.
Yeah.
So these little things could have saved a lot of lives.
This was my concern with the elder care homes. You come in, you have a vaccination program, you come and vaccinate everyone. Well, now people have these depressed immune systems for about a 2-week period, and now they're passing away because they get any bug.
That's right.
Yeah, and this is something I think they could have, I think that's probably, to me at least, and this is my own opinion, I apologize, but it's I think we really did a disservice to the elderly, and I don't think that we, in the postmortem of this, I think there has to be someone held to account for how we failed to protect the people in the long-term care homes. And
exactly. We not only did we forget basic medicine, but we forgot basic, we had no common sense. I mean, there are several, Canada may be very different, right? But in the US, we've had several states. I'm originally from New Jersey, so I kind of know what goes on there. Where they put sick people into nursing homes when there wasn't even a protocol for how you treat infectious disease within a nursing home. Mm-hmm. So I would like to know what genius said, oh, that's perfectly fine. They had no way of prevention, no way of infection control, especially for something that's an airborne virus, yada yada yada, right? Who made that decision? Like, oh, we'll just stick them in. And I think unfortunately, it's probably done for political reasons, because they figured, well, we'll put them back in a nursing home. If they died in a nursing home, maybe not in a hospital, whatever it may be. I think it was a kind of a moving shell game. But I'm hoping that whatever we've learned from this, that will never happen again.
Yeah. Even your much maligned governor of your state, I mean, he had the idea, or someone with some common sense in his office had the idea of taking people who are infected and taking them to a different facility to ride out their COVID, not taking them back to their their long-term care home. And that just seems like such logic. I know I've spoken many times of a doctor in South Africa, and his name is Sankari Chetty, and he
I know him.
Yeah, well, he talks about, he was one of the first persons I heard say, when someone comes in with COVID, I don't wait for a PCR, I don't wait for any test. I send them home with drugs for their whole family. I mean, what an obvious thing to do, to not just treat the patient, but treat those people who are going to be around the patient, because no one is going to live in a sealed environment. They're going to be living amongst people, especially if they're the further down the socioeconomic status there is, they have, then the greater risk the people around them are.
Yeah, we have a great state of Florida. I have to be honest with you. The way that this is currently run with the management.
Well, and I think what he did was he relied on Jay Bhattacharya, Sumitra Gupta, and he relied on people who are have a strong understanding of a pandemic and the response that would be effective.
Yeah. So I showed up at a Regeneron site with a person I know, who contracted it. I have a convertible, so I put the top down and I put my mask on. They had their mask on, so we're fine. And I drove 20-25 minutes to the Regeneron site, and I get there, that person goes in, they see me, they go, well, you're, with that. I said, no, I'm just drove them in the car. You know what they said to me? No, but we can use it prophylactically. We can give you the adventure, super proactive to give me the Regeneron shots. And I said, no, if God forbid I need it, I'll take it, but I don't need it for this particular moment.
Yeah.
But that's very different, the way they treat you here in Florida. A buddy of mine literally this past week got COVID, called me up. He's trying to get treated in New Jersey, and it's been a joke. I mean, he had to go to a friend of his who's a doctor to get a Z-Pack. I tried to offer him help on getting other things, other therapeutics, but he was ready, 6-7 days in, and his oxygen saturation was fine and so on. So he was okay, but he's 68 years old, and so it's starting to approach a risk factor. But in New Jersey, forget it. He asked for the Regeneron, they basically turned him away.
Yeah.
So it's a joke.
I guess the question is, why not? Like you're just going to send the person home. Like Richard Urso, he says, you're not even going to give them a baby aspirin. Like, you're not going to give them anything for, anything to assist in any way, just, good luck and come back if you can't breathe. I mean, it doesn't seem like, I just can't imagine another ailment, disorder, disease where you would say, oh, you seem to have diabetes. Well, come back in a week, when your blood sugar is at, whatever, it's.
I know it's bizarre. It's bizarre. And you look at, other things like the opiate issues and where, people were writing prescriptions, like, a cup of water, and it makes you kind of wonder what's going on. It's just, it's nutty.
Yeah.
It's nutty.
Are you hopeful for the future?
I am. I'm very hopeful. I think we've learned a lot. I'm starting to see people wake up and understand of not only is this a COVID or a viral thing, there's also other dynamics going on, which are, political, government issues. This is bigger than a pandemic. All right. And I think a lot of us have woken up to that. And I think this is going to really make people aware that, certain things that go on in the world, including government, are not always good for the people. Actually, it's the opposite. So I think it's woken up a lot of people, and I think that's going to be good for us. I think it's going to be very, very good for people. And I think this virus, ultimately, the Omicron, right? Omicron virus. Who knows? Maybe this is a mutation one too far, where the virus becomes highly contagious and infectious, but very, very little impact. And wouldn't that be, I don't know, I put this question out to a few really experts. So I said, sir, if this thing goes around the globe and this is highly infectious, but is mild, will this be the herd immunity we all wanted? With no deaths and everybody becoming ultimately immune or having immunity to some other things. So maybe this thing will self-destruct with its multiple mutations. Maybe this is going to go away. Who knows?
We can only hope.
I would hope so. I pray.
Any final thoughts, Stan? Anything you want to again talk about the product, talk about your website, maybe just.
Yeah, well, it's just immunemist.com. We offer occasionally discounts, of course. And Bruce, we're going to be offering a discount for the early treatment group, right? Yeah. Which I will send off to you, but it's I believe it's 20% off if I'm not mistaken, which is very, very good. And so that'll be coming shortly for anybody who's interested. And I want to thank you for the opportunity to come on and talk a little bit about a very interesting, but also area that I'm very passionate about. I've lost a few people that I know to this, and it's been very sad. And I've also seen other people devastated, losing a loved one or husband, so it affects a lot of older men, right? So I know quite a few women that lost their 75 plus husbands, which is, quite sad to see this happen. Yeah. So thank you for the opportunity to share my story and talk a little bit.
Well, thank you very much. I really, really appreciate it.
Thank you, Bruce. Thank you.
hope you enjoyed this episode. Please note that neither the host nor the guest have any undeclared conflicts of interest. Please visit novametricsinc.com for more information about the Canadian COVID collaboration.